It's wonderful to be here. It's my first time in Australia, and I don't think I've ever traveled this far to give a talk before. I was asked to talk about Lee syndrome, then we changed the title of the talk to clinical trials, now back to Lee syndrome. I'm going to talk a little bit about both. Coming to Melbourne to talk about Lee syndrome is much of what we know about Lee syndrome actually came out of this medical center. So. What I'm going to do with this talk is give you a couple examples of some patients I've seen with Lee syndrome, discuss the disease a little bit, talk about clinical trials and what's coming down the line in terms of advancements in terms of the treatment of Lee syndrome and other mitochondrial disease, and wind up with a consortium project that is international, worldwide, and very exciting. So I come from Akron. It's a city of about 250,000 people, and this is the picture of the inside of the hospital. We actually serve a huge population around the state of Ohio, and I'll talk to you about one of the patients I've seen with Lee syndrome. And as I run my clinical trials in Lee syndrome, I do have patients come from all around the United States who have to travel 3-4 hours on plane rides. And one of the interesting things about Lee syndrome is two of my patients, they didn't know they were my patients, but they were they had both flown, one from Texas, one from Florida, through the city of Atlanta to get to Akron. And they were waiting to board the plane, and they looked at each other, and both at the same time said, "Are you going to see Dr. Cohen?" So they recognized that each of their children had Lee syndrome. One of the interesting things about Lee syndrome is all the patients looked at, through one set of lenses, looked very similar, but when you get down to it, everyone looks very different. So although we talk about Lee syndrome as a syndrome or a disease, it's actually many dozens, if not hundreds of different disorders. But this is a classic case of a little girl. And one of the most exciting things about this patient is that in her diagnostic odyssey, it really only lasted a few hours. Because the diagnosis of Lee syndrome was made correctly by two physicians that had never seen or heard of Lee syndrome before that day. And the reason they were able to make the diagnosis is they took interest in this child's case, and they looked stuff up in a book. So she was healthy till the age of 3. She had a non-specific viral infection, really a cold. And as she was coming out of the cold, she woke up one morning unable to walk because of imbalance. And her grandparents took her to the emergency room. And the doctor in the emergency room said an acute inability to walk. Need to make sure the child doesn't have any drug intoxication. But then I know I need to do a spinal tap looking for infection. I need to do an MRI scan looking for a tumor. And so they did the spinal tap, and the initial results come back in 15 minutes or so. There's no infection. They send her down to the MRI scan, and you can see in the middle, this should be gray. It's white. This is the middle of her brainstem. It has been severely injured by some disease process. The radiologist takes a look at this and says, "I've never seen this before," looks it up in a book. And the two possibilities: number one, it's a tumor, or number two, it's a metabolic disease consistent with, quote, Lee syndrome, unquote. So the radiologist looked up what Lee syndrome was in another book and came down on the radiology report, said favored Lee syndrome because of the rapidity of onset. The child goes back to the emergency room. The pediatrician's never heard of Lee syndrome before, looks it up in a book, and sees a reference to increased spinal fluid lactic acid. So calls the lab and said, "Is there enough spinal fluid to run lactic acid?" The lab said, "Sure." They ran the lactic acid. An hour later, it comes back elevated, and the child's diagnosed with Lee syndrome before the sunset that day. That's a pretty amazing story. While she was in the hospital, she developed not only imbalance, but weakness on one side of the body, then weakness on the other side of the body. And then also developed an eye movement problem. You can see this eye her left eye is drifting outward. And these are all common manifestations of Lee syndrome. She got well enough to go home. She developed a movement disorder called dystonia, which is a twisting movement that often accompanies children with Lee syndrome. Over the course of the next 6 months, lost some function in her nerves and developed a neuropathy. She actually recovered over a 6-month period to the point she could walk again. That's when I first met her. And then really over the last 12 years has slowly lost the ability to walk. As of right now, we don't have a genetic diagnosis on her. Now, we have not done the most sophisticated genetic testing we can do, but we have yet to make a genetic diagnosis on her case. So let me tell you a little bit about Lee syndrome. First of all, part of the evaluation can be a muscle biopsy. The muscle biopsy may look normal under the microscope. A lot of the information that you've seen about muscle biopsies is you do them to see the abnormal mitochondria under the microscope, but in Lee syndrome it can look normal. But if you do enzymology, and really the best enzymology in the world is done at this medical center, you can sometimes tease out whether it's due to electron transport chain 1 or 3 or 4 or 2 or whatnot. Clinically, most of the patients with Lee syndrome develop problems with their brain and nerves and not with other organ systems in their body. Now, that's not an absolute phenomena, but what's different about Lee syndrome than I think of other mitochondrial diseases is that the disease burden is heavily concentrated in the brain, spinal cord, and nerves, less so in heart and kidneys and other organs of the body. We've heard about the mitochondrial DNA and nuclear DNA genes that can be involved in Lee syndrome. And at the last count, there's I put 75 plus because the standard on our national websites are 75 plus, but there's probably closer to 200 genes that have been involved in causing Lee syndrome. It's not clear why some mitochondrial genes cause Lee syndrome and others do not cause Lee syndrome. Really, you can wave your hands and try to explain it, but not a great explanation. The true age of onset is between 1 month and 40 or more years of life. And the overall prevalence of this is about 1 in 40,000. Although there's some populations where the prevalence, there's a small area in Canada, 1 in 2,000 in the Faroe Islands, because of closed population, the disease frequency is 1 in 17. So I'm going to tell you about the next diagnosis. And this was made by a junior physician who just finished 3 months working with me on child neurology. It was his first night on call back on the adult neurology service. And he made the diagnosis of this patient. So this was a 26-year-old woman, previously healthy, who was admitted to another hospital several months prior to that with an acute psychosis. And they treated her with a medication used to treat psychosis, and she got better. But 9 months later, presented back to that same hospital with psychosis and a movement disorder called chorea, which is jerky movements of the arms and legs. She had a CAT scan performed which showed calcification in the deep part of her brain and was transferred to the adult neurology service in this unstable psychiatric state. My resident took a look at the CAT scan, took a look at the picture and said, gosh, could this be a mitochondrial disease? And did a spinal tap specifically looking for lactic acid and abnormal amino acids because he was thinking mitochondrial disease. And the spinal fluid lactate was I would say, moderately to massively elevated and consistent with the diagnosis. And that evening, we started her on coenzyme Q10, and she remains on that drug till today. You can, from a functional point of view, you can have a perfectly normal conversation, but when given tests to look at higher intellectual functioning, there is some impairment. And she had one additional episode of encephalopathy in 2007 that took about a month to resolve, a milder one in 2012 that resolved. And her blood lactate remains elevated about twice the upper limit of normal. Overall, there's been no change in her intellectual abilities. This is a copy of her MRI scan showing injury to the deep parts of her brain. So what would we call this disease? The diagnostic evaluation in 1997 really didn't give us many clues, and we were limited by genetic testing back then. There was no evidence of maternal inheritance then or now. She has a mild dementia, poor long-term memory, poor coordination, but you can have a perfectly normal conversation about politics with her. Analytes showed lactic acidosis, abnormal amino acids, elevated spinal fluid lactate. We did a muscle biopsy under the microscope. The muscle looked perfectly normal, but biochemically there were some severe abnormalities that I'll show you on the next slide. And genetically, back in 1997, I could only do a limited number of genetic tests, and those were normal. Here's her enzymology, and I'm just going to point out some of the highlights. When we look at how fast electrons flow through complexes 1 and 3, the number we got on her mitochondria was 6.1, normal is 481, so that's about 1.5% normal. So that's severely affected. As we look at how electrons flow through complexes 2 and 3, that's about 1/3 normal. And complex 4 is about half normal. We really didn't know what to make of these data back then because, again, we kept saying if we only had genetic testing, we may be able to get an answer. And so in 1997, I just looked through my chart and started looking at the things that I called this back then. I called it Forest disease, which is calcification of the basal ganglia, mitochondrial submyopathy, atypical MELAS, atypical Lee syndrome, complex 1 disease, CoQ10 disorder, because she responded beautifully to CoQ10, and so forth and so on. But when we finally did the genetic testing that we could do in 2010, she ended up having a mutation in a mitochondrial DNA gene. And there was one other reported case in the literature calling this adult onset Lee syndrome. So you can see that there's some similarities between this early childhood case and this adult case, but again, also vast differences in how patients ultimately look. So let's talk about what a typical Lee syndrome presentation could be. The onset is generally in a pregnancy healthy within our young child, but I did show you a case of an adult. With generally an acute or subacute loss of an acquired milestone, there's just a huge number of variations on this thing. So there's no one thing I can tell you to look for. Sometimes this occurs in the setting of a viral illness. And we really are not sure why that's the case. We think it's a metabolic stress of the temperature or maybe the dehydration, but we really don't know for sure. There's invariably some stabilization in the disease followed by progression of symptoms, which may or may not begin for many, many months or years. One of the common things we see in babies is low motor tone. They become very floppy, and this floppiness is often replaced at a year or two of life by dystonia, which is a slow, twisting movement of the body. Ataxia is the medical word for poor coordination. There can be eye movement or facial movement problems, loss of muscle stretch reflexes. There can be heart or kidney involvement. Not commonly, but when it happens, it can be big. Loss of the optic nerve fibers, and that causes optic atrophy and poor vision. We have loss of cognitive function, although this is not always the case. Swallowing difficulties because of the brainstem injury that controls the ability to chew, suck, and swallow. And ventilatory difficulties. This could be due to chest wall muscle weakness, low muscle tone around the airway, causing airway collapse when the person tries to breathe, or injury to the brainstem, which is the drive for breathing. So again, I put the word typical in italics and quotation, over here because there's really no such thing as a true typical presentation for someone with Lee syndrome. How do we do the evaluation? This has changed dramatically over time. Just to cut to the chase, back in the olden days, muscle biopsies were almost universal. In the year 2010, I had ordered over 100 muscle biopsies of my patients. In 1 year, over 100 muscle biopsies. I've done 3 this year. Why? Because I have genetic testing to fall back on. Muscle biopsy and the full evaluation, which I'll show you what it looks like. I'm not going to go into the details. Back in the day, ran about $40,000 US. Okay, I can get whole exome testing for $999 today. So which way would you go? One requires an operation, the other requires a mouth swab or something. So punchline is that the evaluation has changed over time, but pretty mandatory in any person that you would consider leasing would be to do the brain MRI, looking for those central areas of brain injury. We would do evaluation of each organ system that needs to be evaluated. So it doesn't mean I do a total top to bottom evaluation, but we do take a look at the important organs or if there's any evidence of organ system dysfunction in any one organ. So those are tests for the brain would be testing of cognitive function, doing an electroencephalogram looking for epilepsy. We could send the patient to a physical therapist for gross fine motor function. I do a dystonia evaluation in the office at the bedside, and the taxi evaluation is all part of the exam. We look at muscle strength, we look at visual acuity, hearing function. Ventilatory function is a lot easier said than to be done. There are two ways to do this. In a cooperative adult, you have someone do a pulmonary function study that requires a mask or some appliance over the mouth. The person needs to seal their lips over that in a cooperative fashion and blow really hard. The technician who does this test screams at, if you ever had it done, they'll scream at you, blow harder, you're like with a whip. So you really can't do that on a 2-year-old, right? It's just not going to happen. When we have to do it on a 2-year-old, it requires the application of the mask forcibly over the child's mouth, and then what you're really measuring is how hard they can suck in as they bite you. So that sometimes has to be done, but it doesn't really give you the data that you need. So sometimes we fall back on a sleep study, which can look at air movement in and out of the lungs and give us some idea about ventilatory function. But this is incredibly important in our patients with Leigh syndrome. And I'll get back to this in a little bit when we talk about how we treat. We may want to look at heart function, kidney function, liver function. Many of these are non-invasive and be done by very simple non-invasive studies, and look at swallowing and gastric motility, and then we get down to the business of is it mitochondrial disease or not. Now this is my typical lab evaluation that sort of spanned when I entered clinical practice in 1989 up until the genetic error that really our ability to do that exome test began at around 2013. So this is what I really relied on, this massive array of blood, urine, spinal fluid testing, muscle biopsies, MRI scans, sending the skin biopsy off for analysis. This could take a year or two to get all this stuff done. And then as genetic tests came online, one after another, my reliance on all these other tests decreased. So again, I talked about the cost of the evaluation in the United States was about $40,000 to do the spinal fluid and muscle biopsy, and the cost of the exome, again late this year, is under $1,000 US. How do we take care of Leigh syndrome? Well, supportive care, organ system by organ system, really is the mainstay of therapy. I have a discussion early on about the implementation of gastric feeding tubes and medication for feeding, use of the gastric tube for medications and for feeding. This is a hard discussion to have because no one really wants to think about a gastric tube for their child. But one of the things that I found in my practice is that those children who I suspect are heading towards that way do better if they get it early. Because if you get a jump on 6 months of malnutrition, the child could be better off. Again, difficult, easy for me to say up here, very difficult to have in the examination room with my patients. And the same thing is true about the tracheostomy. A very difficult conversation to have because the tracheostomy changed everything. It's in some respect it's an admittance of defeat that you're going to get on top of this disease. But again, if the child is headed in that direction, the best time to do it is way before the child actually needs it. And my observation, having taken care of enough kids over the course of time, is that those kids who get it earlier actually fare better off in the long run and have fewer hospitalizations. Then we talk about the use of supplements. By the way, I took that hour discussion down to about 30 seconds. So discussion about the use of supplements and discussion about the use of aggressiveness in care. And so how hard we're going to push on this disease, or are we going to basically throw our hands up in the air and say, we give up on treating this aggressively, let nature take its course. And more and more of my patients have gotten aggressive over the course of time. Maybe that's because I've gotten more aggressive over the course of time. I want to talk a little bit about supplements, because this is, up until around 2008, this is what my patients were on. I learned mitochondrial disease from a couple mentors, and this is what they used, so this is what I used. Dr. Solomarian was talking about niacin before, but pretty much these are what my patients took up until 2008. Then there was pressure, there was review of the scientific literature, do any of these do any good? Pressure from my colleagues saying you're prescribing way too many vitamins. My parents were telling me that they're spending their day and night trying to get the vitamins into patients. This is not inexpensive. If you add up everything on this list, and if this is folinic acid, not folic acid, this ran about $8,000 per year for an older kid, so it wasn't inexpensive to do this. The bottom line is that this shotgun mitochondrial therapy doesn't make a whole lot of sense. I'm not saying it's wrong. Okay, a lot of my patients still take all this stuff, but it doesn't make a lot of sense. Number one, it's one approach to hundreds of different diseases. Number two, I'm not able to judge which of any of these are helping. It's expensive. It can really only be carried out by overly compulsive doctors, patients, or parents, because, again, well, many of you have been down this route. It isn't easy. As a prescriber, I was viewed as a vitamin pusher by my colleagues, and it seldom met therapeutic goals. So I backed away from this on as an aggressive approach on most of my patients. Some can, I offer this to my patients, but most take way fewer than that. So what are my typical treatments? Whatever exercise patients can get, whether it be physical, occupational, or speech therapies, or actual exercise like a healthy adult can do, is what I recommend. All my patients with these get polysomnograms, sleep studies, because there's a lot of treatable pathology. And what we find out is with a lot of my patients, if they don't need a ventilator or tracheostomy, but they often do need some ventilatory support at night with BiPAP. And we were able to use BiPAP effectively even in kids under the age of 5. They actually get more air into their lungs forcibly, fewer infections and hospitalizations. I keep my patients well hydrated. Here's a list of my basic supplements. The ones, the arginine and citrulline, basically reserved for my MELAS patients, not for my Lee syndrome patients, but again, feel free to take pictures of this if you'd like. A lot of people with mitochondrial disease have constipation, so we do use the medication called polyethylene glycol. We try to avoid stresses. The big ones: illness, fever, starvation, and sleep. And then
try to avoid sleep.
No, try to make sure you get plenty of sleep. And then talk about clinical trials. So, clinical trials in Lee syndrome really had its birth not too many years ago. And the trial in the United States that has really looked into treating Lee syndrome is with a drug called EPI 743, which I'm going to say a few words about. The next two slides I'm going to talk about what's obvious and what's not so obvious with clinical trials. The first thing is that there are many mitochondrial diseases, and it's not reasonable to think that one therapy could work for many or all of them. So with this EPI 743 trial, we said we're going to limit it to Lee syndrome. But of course, as I told you, Lee syndrome can be caused by at least 75 different genetic mutations. Mutations in 75 different genes. And so we may be treating a broad spectrum of disease, even if we do only treat Lee syndrome with this drug. There are no FDA approved therapies for mitochondrial disease, and I use FDA as the term FDA in the United States. That's the Food and Drug Administration, which controls the use of all prescribed medications in the United States. For the therapies that are available, those are the vitamins that I was talking about. Few patients are benefited. There are some exceptions, so I do have patients who had, started coenzyme Q10 and had a remarkable change for the better in their level of functioning. But most of my patients, when they start CoQ10, really can't tell me that things are different, and will go off of it for several months and then go back on it. And they really can't tell me that things are truly different on the CoQ10. We obviously don't have highly effective therapies. If we did, we wouldn't be sitting here right now. One of the big things is that when we started all this discussion in 2009, when we started designing the trial, we really had no knowledge of what success would look like. So we didn't know if we were going to be given a medication and children were going to be able to recover neurologic function and walk again. We really did not know what we were going to see. And then a problem that existed in 2009 and exists as we enter 2019 is we still don't have a great natural history data on Lee syndrome. And part of the reason is that, as I said, there's 75 different genes. And what we're starting to see is that Lee syndrome from one gene may be far worse than Lee syndrome caused by another gene mutation. And until we know what naturally happens without treatment with Lee syndrome, it's hard to know whether the treatments we're prescribing are helping or not. So when we all started sitting down, we weren't sure how to measure success. And sometimes when we sit down now and really have a deep discussion, we're still not positive that we even know what success looks like now. And I'll tell you what we found. So this is the drug UPI 743 right here. It looks sort of like coenzyme Q10. The difference with UPI 743 is it actually gets into the brain much better than CoQ10. CoQ10 doesn't get into the brain at all. UPI 743 gets in somewhat. Ventilatory, which you've probably heard about, gets in better. And there's a drug that really hasn't reached clinical trials. It's been around for a long time called Mito. Gets into the brain just fine. So for a couple of reasons, EPI 743 was chosen by the company that owns the patent to investigate for Lee syndrome. And so this is a click off of a website called clinicaltrials.gov. This is a US-based website. Any clinical trial has to be registered and registered on this website. So the nice thing about the website is you can go in and you can type in EPI 743 and everything being done on EPI 743 will come up. Or you can type in mitochondrial and everything on mitochondrial disease will come up. So this is how it lists. This is an old slide, so it's been updated since then. This is the day that the trial was received by the clinicaltrials.gov website. And you can tell, I'll give you a little more detail. When you look this up, this condition, Lee syndrome, the intervention is placebo, high-dose EPI 743 or low-dose EPI 743. And let me tell you a little bit about the trial. And it's sponsored by a company that was known as Edison Pharmaceuticals, now it's known as BioElectron Technologies. Same company, different name. Everyone likes to rebrand themselves every few years, even if you don't have anything to sell. The company does not yet have anything to sell. There were 4 treatment sites, my site, Baylor, Stanford, and Seattle. The trial was 36 patients. Patients were randomized. 12 patients were randomized to receive low-dose EPI 743. 12 patients high-dose EPI 743, and 12 patients placebo, okay, which is, sugar water. It's not a treatment at all, for 6 months. After 6 months, all patients on placebo went on to the high-dose EPI 743. And so what we're really looking at is what happened during the first 6 months of study And then for those kids on placebo, what happened to them in the first 6 months, and then what happened to them in the second 6 months. So the study was designed as a year-long trial. Now what happened by the end of 2013, when we had all 36 patients on the study for a year, is the company realized that that's not enough data to send to the Food and Drug Administration for FDA approval. So all patients were allowed to remain on the drug at the high dose after a year. So we've had patients on this drug now since the middle of 2012 and have a lot of data about how they've done. The primary outcome measure was the Newcastle Pediatric Mitochondrial Disease Scale. That's a disease scale that measures disease severity. This scale was not designed for clinical trials, and in fact, when we looked at the data, and we're looking at it yet again, it doesn't look like the patients improved their disease scale on being on this drug. But we also looked at what are things called secondary outcome measures. Their neuromuscular function, how they did gross motor and fine motor. This is a dystonia scale. We looked at respiratory function, basically the need for tracheostomy, disease morbidity, which is the total number of hospitalizations, some biomarkers, number of adverse events. Now, for a trial person, what does an adverse event mean? For someone with Lee syndrome, an adverse event could mean a brainstem stroke. That would be a big adverse event. Adverse event means hospitalizations from any cause. So if you get a kidney infection, that's an adverse event. If you trip on the sidewalk and chip a tooth, that's an adverse event. And we looked at mortality. And as it ends up, the children who were put on the drug initially, at the beginning of that first trial period, had fewer adverse events in the first and second 6 months of the trial than the children started on the placebo. Now, we're just re-looking at the data set again. A couple weeks ago, the data set was sent over to us, and lo and behold, we found that there were some missing patients. In other words, the data set that had been analyzed up until now, we actually have more patients on the study than was in the initial data set. So we're actually pulling all that data as well. And hopefully we'll have something to report in a professional paper sometime in the next 6 months. That's being run by Dr. Greg Enns out at Stanford. So we're putting all that together. So many people look at this study as a failure because we did not change the disease scale score. And the FDA is looking at this, is looking at number of adverse events. They're also looking at mortality, okay, because the natural study, history study that we have about Lee syndrome is that a lot of the patients with this disease succumb to it. And that's not what we're seeing on the study. Most of our patients are alive, doing well, without hospitalizations. When I say doing well comparatively to the illness burden that they had when they entered the study. So the FDA is actually considering this for approval for treatment. We're not going to know for a year or two. So getting back to why Lee syndrome is difficult to evaluate, the meatloaf analogy is not my analogy, but I like it. So imagine as you slice into meatloaf. With Lee syndrome, I've got to ask myself the question, does the patient have a cardiomyopathy? Yes or no? The answer is yes. Is it less severe or is it more severe? Okay, so then I've also got to follow the cardiomyopathy through time. So if the answer is no, we can dispense of that and move on. Next question, dystonia. Less severe or more severe? And then we have to follow it over time. If you look at a 1-year-old with Lee syndrome, they do not have dystonia. Okay, they're too young. At 2, they start developing dystonia. At 3, 4, 5, 6, 7, it really gets pretty severe. Okay, and then I've got to follow that issue over time. That's the natural history. But how does EPI 743 affect that? We don't know. Does the patient have areflexia? Does the patient have myopathy? Does the patient have optic atrophy? You remember all those neurologic findings and non-neurologic findings I had on one of the earlier slides? We've got to look at the patient through each of those slices every time we see the patient and follow that over time. That's an incredible amount of data to have to follow and score and grade appropriately. So here are challenges. Finding patients for the study is not easy. The natural history for Lee syndrome hasn't been defined. We're talking about a huge commitment from our patients. I have a patient who, as I told you, comes from Florida. I've been seeing the patient since 2013. This child has made 21 round trips through Florida. Gets on a plane in Florida, flies through Atlanta to Akron, rents a car in Akron, spends a couple nights at a hotel in Akron, both parents, okay? And then goes back through Atlanta, back to their home in Florida. It has to do that every 3 months. So that's a huge commitment on the family to be part of the study. The cost of doing this, and that the burden of the cost is actually on the sponsor, the company that actually wants to get this drug approved. It's about $2,500 round trip. So just multiply that out. The company spent about $100,000 getting the patient to participate in the study just by getting them to come to Akron. And so we're talking about the total cost of the study somewhere between $250,000 and $300,000 per patient over about a 5-year period. We can't predict what patients are going to have the best chances of responding. Boy, it would be nice if there was a blood test to tell us about disease activity. There's not. Lee syndrome may be 100 different diseases, so we may be fooling ourselves in a study of 36 patients and think we're ever going to find anything. And finally, we have to ask the question, does the standard trial design for ultra-rare diseases, is it appropriate and does it need to change? I entered my career not as a mitochondrial doctor, but as a brain tumor doctor doing clinical trials. And I ran a clinical trial where we expected to be able to enroll 250 patients a year in that clinical trial. And the trial endpoint was very easy. Does a patient remain in a remission or not? Okay, there was no meatloaf here. All I had to answer the question is, was the tumor gone or was the tumor back? If the tumor was back, the trial failed. If the tumor was gone, the trial succeeded. That's a lot easier, a lot cheaper to be done with an MRI scan, and again, no slicing through dozens of different clinical criteria. And so the trial design that we're using now is the same as the trial design doctors use to look at things like lung cancer and brain tumors. Very easy questions to answer. Bad diseases, rotten treatments, okay, but very easy. Does the drug work or not? So, just moving on, I'm going to tell you about a coordinated effort between some of the major mitochondrial foundations in the world, including the Mito Foundation here, UMDF, the Lilly Foundation, Mitocon. And we're actually on what we call a Lee syndrome roadmap project. I get to be the principal person trying to conduct this project as a conductor would conduct it. Not that I'm playing any of the instruments. And our goal is to impact the lives of those affected by Lee syndrome by developing coordinated projects worldwide. Right now, we're in the process of interviewing all the major players around the world in Lee syndrome and trying to set up a body of a working body to raise money and dispense funds so that we can get these projects actually conducted. So right now, I'm pleased to announce that we have over $1 million already, US dollars already pledged from the principles I had showed you on the prior slide. That was our near-term goal. We started this about 6 months ago. Our long-term goal we haven't set, but realistically to do all this, we're talking about $5 to $20 million. So we do have money that we need to raise. We chose Lee syndrome as a starting point, not because it's the beginning and end of all mitochondrial diseases, but it's because it was something that we felt we could wrap our hands around. So we have some guiding principles. The first guiding principle is global involvement. The second is the fact that the people who actually can do the work in this are also the experts, and so we're asking people for advice on where we should spend the money, and actually the money may be coming to the same people that are giving us advice. We understand that. The projects are going to actually, we use the word promote collaboration, but we're actually going to force collaboration. So if someone thinks they're going to put together a project that's going to be a single institution project, it better be incredibly powerful, because what we're really looking for is international collaboration. And we're involving everyone in the mitochondrial disease community, the academic researchers and clinicians, the industry, and those are the people that hold the patents for these drugs, patients and their caregivers, and then we're going to have to bite the bullet and actually deal with the healthcare delivery system. That's the federal governments or the European Union that we all really have to work under. Because unless they buy into this stuff, we could have a treatment we won't be able to implement it. So I'm not going to go through the details of all this, but this is where we look like we're heading. But I do want to point out that we still need to define the natural history of Lee syndrome. We've got to establish consensus on clinical guidelines for how we take care of patients with Lee syndrome outside of the exploration of does a drug work or not work. We have to have improved genetic testing. So we're talking about a global way of doing genetic testing for Lee syndrome. We are looking at projects that are preclinical. That means outside of human beings, but directly applicable to humans. Creating the infrastructure for running these clinical trials that would be low cost and high value, and capture, again, the natural history. If we can find a biomarker, that's great, but we're not going to concentrate on millions of dollars and try to develop that biomarker. So when we look back on childhood leukemia back in 1950, it was a fatal disease generally within weeks. And then when we looked at what it took it took 10 years before we started seeing any improvement in the common form of childhood leukemia. And then really by the year 2000, 2010, we're looking at an 80% survival rate. AML, which is an uncommon form of leukemia, a little slower down the line. But it takes a coordinated, well-funded effort, about 20 years for cancer. Okay, so we can dream about being there in 5 years, but the reality is that